Here you go. Oh no.
Yeah, Mom, I need love of my girls' blankets.
Okay.
And if we do anything for young women that are survivors, then if
Yeah.
it goes
Yeah.
out to the sympathy blankets.
They go live.
Hello, everyone. I believe we are live now. We're here with this month's Pink Table Talk. I'm very excited to have this group of women with us today. It's going to be a good one. And just ground, actually, we'll do some introductions, then we'll kind of dive into like why we do Pink Table Talk and take from there. So I'm Haley Brown. I'm the director of programs and partnerships at Touch the Black Breast Cancer Alliance. And we're here with our For Love of My Girls campaign today on our what's supposed to be our March Pink Table Talk. We are doing in April because our usual day would have been Easter. So we wanted to wait a week. So Dr. Candace.
Hi, everyone. I'm Dr. Candace Thompson. I am a breast surgical oncologist at Stanford University. I am really excited to be doing today's Pink Table Talk to talk about fertility. And I am one of the co-hosts, or I am the co-host with Haley for this show.
Yes, yes. And now let's hear from Dr. Alexia, who I haven't seen in such a long time. I'm so happy to see you.
Good to see you. Hey, beautiful people. I am Dr. Alexia. I am a triple board certified physician. I'm also a stage 3 breast cancer survivor thriver, a mom, and a breast health advocate, and excited to be here for this conversation.
Yes. And then we recently met this wonderful woman named Rhonda here. So I'm really excited to get to know you and hear all about your story.
Awesome. My name is Rhonda. I am the lead her of Tata Tuesdays, creating safe places for all of my breast friends, whether you're a survivor, a warrior, a griever, a caregiver, a preventer, all of hers. We are welcoming you into our community.
Awesome. And Val, you made it just in time. And I'm really excited because Val and I have never done a talk show together. So we get to do one together today. Val, who are you?
I'm Valerie Worthy. I'm a 25-year breast cancer survivor and co-founder of Touch. Happy to be here, Haley.
Yes, yes. Val is very much my second mother. They go back and forth between who claims me on various days, but I'll take them both. I'll keep them both. Yeah. So today we're here again to talk about Black breast health and fertility. Kind of just want to ground us in why For Love of My Girls exists and why we're having this conversation today. Because Pink Table Talk is really generally geared towards young women 18 to 35, young Black women 18 to 35, not yet affected by disease. But I think this show is so important because it reminds us how intense fertility is without disease. And then we add that to it and all the things we should be thinking about as young women as we are experiencing life. And so it's really important to hear from women like yourselves who are survivors to come and be a part of this fertility conversation. And so again, Black women, under 35 get breast cancer at 2 times the rate and die at 3 times the rate. That is why For Love of My Girls exists to, help young women unlock her story, learn how and when to check their girls, dive into their own Black breast health, all of that. And then the recent stat that I wanted to share with you as well that I think I have written down here, is that Black women ages 20 to 29 have a 53 increased risk of breast cancer compared with white women of the same age group. And so when I think about those two things, I think about that's why we're here to have these conversations and kind of dive in. So the medicine that really we want to talk about today too is Xeloda. And I know that the women here have had experiences with that, and I would love to, or no, Zoladex.
Okay.
Zoladex. I was like, what? For some reason those two are confused for me. So Zoladex, yes, I saw your faces like, what? Not the right thing. Yeah, so I'd love to kind of just jump into your stories and hear about your journeys with Zoladex and Black breast health and Black breast cancer and all the things. So anyone can start. Val, you want to start?
Yeah, absolutely. So I was diagnosed at the age of 40. So I think at 39, I had breast cancer in my body, just hadn't been diagnosed, but I was still having a period. And so I went through chemotherapy, which was adriamycin, Cytoxan, and then Taxol. And maybe a few months after my last treatment, my period came back on. And so my oncologist had a conversation with me, and he said, I didn't want your period to come on as soon as it did, as fast as it did. So there is a medicine called Zoladex, and it's an injection, and you'll get it once a month, and it'll keep your period off. But, you know, we also believe that it'll help you in terms of longevity, in addition to, you know, stopping your period. Because I had my cancer was fed by estrogen. And even though being a nurse, there still was a lot of information to absorb. But I had a great relationship with my oncologist, and I trusted him at the time. And I was even, believe this or not, confident enough thinking that, oh, just an injection. I'm a nurse. I can give my own self the injection. When I saw that big needle, I said, no, hell, I can't give myself this injection. No way. I mean, it was the biggest needle. And honestly, it was a painful injection. So literally, I had to have an ice pack over the site before I received the injection. But after a bit, it became not so painful, but it was lasting for a long, long time. And so I had a discussion, long story short, with my oncologist about how much longer did he think that I was going to be on it. And he said, probably for quite some time. And so I had a conversation with my GYN about getting a hysterectomy, because I hadn't planned to have children. And so I went down that pathway and eventually had a hysterectomy.
And how often
Did you also have your
sorry.
You also had your ovaries removed, Valerie, I think.
I did. And I had a big fight with my insurance company because they didn't want to pay for the surgery. And the letter that I received was that they said ovarian ablation was not the standard. So that's why they refused. But I had friends who were pharmacists, so I got them to price it out. And I asked my GYN what the cost would be to have the surgery. And in fact, it was cheaper for me to have the surgery than to continue on the Zoladex, because it was pretty expensive. I forgot exactly how much, but I know it was in the thousands. And so when I sent a letter in rebuttal back to the insurance company, they reversed their decision and allowed me to have the surgery. But, you know, I think about all the women who didn't have those resources to get the numbers, to pull all of the evidence up, you know, to support.
I was literally gonna say you're so resourceful. You know what I mean? Like not everybody even like has the, you know, the know-it-all to just like go look, you know, or like know that that information exists to find, you know? And so I think that
it was all about money. You know, it had to be. That was the only other reason. It was about money. So when insurance found out it's less money, they had the surgery. It's not about because they cared about this African-American 40-year-old woman. It was the money. Really, it was. So
and it's so crazy because like these medicines are what you need to get rid of your breast cancer, you know, or like to like maintain that. And so it's like crazy that like insurance is such a fight still. Yeah.
Right. But I did not find out until last year what Zoladex, I mean, like being on it for that time really did in terms of, you know, me being cancer-free. I had no idea at all until I walked by a booth, I think at San Antonio. And I was like, I was on that like 25 years ago. And then, you know, I was talking to the rep and they explained all of the great studies and the findings that came out. So I was pleasantly surprised to know that.
That's nice.
Yeah. I was just going to say it's very telling because now that is the standard of care. So along with breast cancer treatment comes this really important conversation about what you're going to do next. I was diagnosed at, how old am I? I was diagnosed at 40. Was my first mammogram. I found it myself. And I rung the bell in September of last year. And so my Zoladex shots maybe started like soon after I was on Zoladex. It was painful, but not like the worst I had experienced comparably. You know, chemo is rough. So the ice packs definitely helped. And then my doctor explained all the health benefits, you know, of the Zoladex and how it does. It can keep you going. They did offer me an oophorectomy. That is where I stopped because right now I'm surgeried out. Like I'm not in the mood for any more surgeries. The course with Zoladex, I believe, is 2 years standard that I have to be on it. I'm stage 3 estrogen positive. So they gave me that along with letrozole, and I'm also on Verzenio. That's my cocktail. With Zoladex, the side effects that I experienced, and I was blaming this all on at first it was anastrozole. I thought it was anastrozole that was the problem, but then I wasn't taking it because I was preparing for cosmetic surgeries and my bones still hurt. So I said, oh, well, it must be the Zoladex. All of them are reducing estrogen, which causes a lot of joint and bone pain. So that really pretty much is the only thing. That and the hot flashes, which do intensify to me when you do take the anastrozole or the letrozole, but the Zoladex specifically plays into my bone pain.
Wow.
Alrighty, well, it's a good time for me to jump in with my story. So I was diagnosed with stage 3 breast cancer at the age of 37, and then subsequently diagnosed as having a PALB2 genetic mutation. Had cancer in both my breasts. I did bilateral mastectomy, chemotherapy, radiation, and I too am on Zoladex and letrozole. And yeah, that is a big, fat, juicy needle. I've used some big needles in my time as a physician. And I remember getting my first Zoladex injection, and I said to the nurse, oh, let me see that. And she said, well, let me put it in first, because if I let you see it before I put it in, you're not going to let me put this needle in you. And you know, I think people have this false sense about pain. Like if you've been through enough pain, needles and other injections somehow are less painful, but they're not, right? And so to go get this big fat juicy needle jammed into my belly every month is always like this like harrowing experience. But I show up because I know that this is part of the long-term plan to keep me alive and cancer free, you know, even with the potential side effects that are there. And I'll circle back to the conversation around fertility for a second. Like when I got diagnosed at 37, my oncologist had said to me, you know, I'll give you 2 cycles of IVF if you want to pursue it. And about a year and a half before, outside of the conversation of cancer, my GYN had suggested that I freeze my eggs. She's like, listen, like you're at a crossroads, your eggs are the best they're ever going to be. Like you should really consider this. And I was like, whatever. I got a boyfriend. If it's going to happen for me, great. If not, okay. And when I got diagnosed with the breast cancer, I was in the same relationship, and we had had a conversation about not having children in the context of this relationship. And I sort of felt like, well, there'll be other babies in my life, so it's fine. I'm gonna go ahead and hurry up and get this chemo done. And quite honestly, I really don't know if I had eggs or embryos stored if I would use them, but I would have loved to have the option. But that conversation wasn't really had in depth. And I feel like my oncologist took that out. Like, okay, she doesn't want to pursue it. I'm not even going to press forward with the conversation. So now this is my 5th year of Zoladex injections, and my oncologist plan is to have me on this stuff for 10 years. So, you know, for me, children and a pregnancy is out of the question, or more children. I have a daughter. But I think it is a conversation that is important to have before you ever find yourself really truly needing to have this conversation, or really having to think about it. Like there was a lot on the line, and at that time I chose my life over like an imaginary baby. But in the reality is it's not an imaginary thing, it's a very real thing, and it's a very tangible thing. And I love to be a part of this conversation so that, God forbid, if somebody finds themselves needing to pursue cancer treatment, they'll make somebody pause and pump the brakes and give them the pros and the cons and exactly how much time and what does the data say. Because now we do have the benefit of data about what happens when women stop these therapies to become pregnant and what's the long-term consequences, as well as, okay, well, even if you don't freeze an egg or an embryo, what can you do to preserve fertility while you're on treatment?
Yeah, no. And I think I think that's why this is important. This conversation is so important. It really is. And I think, and before this is a fun one for me too, because I can like just learn during this conversation today. I feel like I'm learning so much. But like my best friend who's still teaching, she recently, we were just like both talking about our own fertility, right? Just like having a normal conversation about it. And um I always thought that, like, you hear of a Google or an Amazon allowing people now freeze their eggs, right? They can like do that for free as a part of working these companies so they can prolong how long someone's working, right? And
Mhm.
so recently I found out that my friend who's a teacher, she can do that too.
Yeah.
Like even in the teaching
Yeah.
profession, they're doing that now. So it's just like this conversation is so interesting. And then you add on, it's just crazy.
I
I,
you have a question, sorry.
I was just going to say, I love that people have options. Now, my story is different. I've been self-employed since 2008. And as a result of Obamacare, I was paying for all of my medical visits out of pocket. I had worked out arrangements with my doctors because me paying $600 a month as a single person with no dependents for insurance that I may not even use that month was ridiculous. So when I discovered my breast cancer, I didn't have health insurance. I self-paid everywhere I went first. And
Wow.
then I went to, I think it was right around the time of open enrollment for Obamacare. United Healthcare kicked me out, said, oh, well, because you found your breast cancer first, you now have a pre-existing condition and we can't cover that. So my agent found Better. I live in Florida. My business are based in Baltimore. Better was great, but they could not have an IVF conversation with me at all. So I didn't even have the option unless I was going to be a self-paid person. I believe the consultation fee was $500. And then like going into it was going to be 10 or 17,000. And I was like, man, I really can't afford a kid now. I know I can't. So it was not anything that I could financially do. So I think it's great that people are in professions that allow them to have the conversation, but it's a lot of us that we just can't. Once you find out this is what's going to happen to your body, you just have to go with the steps. I know a lot of my girls are in deep therapy because they found out young, and this has slowly changed their lives. One specifically I'm thinking about, she stopped taking her medicines after 2 years. And was so excited. She called me, Rhonda, my period came on. I'm so excited. I was like, okay, great. Woo, I'm happy for you, because she wants to have a baby so badly. And she was one of the ones that could not afford to freeze her eggs.
I'd like to say something. You all brought up excellent points, and thank you so much for sharing your stories. For the listeners that are watching who are like, what is Zoladex and why is everyone taking it and when is it prescribed? So patients who have breast cancer who have estrogen receptor positive breast cancer, meaning that their breast cancer is growing whenever estrogen is around, they need a medication in addition to the pills that we give them in order to help suppress their estrogen production, especially for their ovaries. So you probably heard everyone mention having their ovaries removed, also known as an oophorectomy. That is an alternative that we do speak with patients about whenever they have this and they're younger. Zoladex injections, as everyone stated, is a monthly injection that we give to patients who are estrogen receptor positive and premenopausal in order to suppress their estrogen production from their ovaries. It is something that has been shown to increase survival and decrease recurrence of breast cancer for these patients. So it's something that's very important. And then having your ovaries out, or an oophorectomy, having your ovaries removed, is something that's an alternative to this. Both of these are supposed to be covered by insurance companies. And as you can imagine, being a young woman, it's very difficult to go through that and not know what's going on as far as future family planning. So we typically try to have a good conversation with our patients about this. The insurance companies are supposed to cover any infertility sort of egg retrieval process that you're going through when you are going through cancer treatment now. I recently went through egg retrieval, and every single time they're like, "Are you a cancer patient?" Because if you are, it's covered. So it is an arduous process, but we can talk a little bit about egg retrieval if you'd like, or we could do a different talk about it. But it is something that I highly recommend for patients who are younger, because you don't know your future necessarily, especially when you're like in your 30s, 20s. So it is something that can be beneficial to have in your back pocket for the future. And it can take multiple rounds for you to be able to harvest enough eggs for the
And to
future.
Rhonda's point, what's the cost of that if you don't have insurance?
The cost of that can be upwards of $20,000. And even when you do have insurance, you can get a hefty bill, as I just did recently, because the medications alone can cost like over $10,000. And then you have the actual retrieval. And then you need to get a certain amount of eggs in order to have like a safe number to like guarantee that you will have a viable pregnancy. So it is a long process.
At what
You
age?
paying for the storage though as well, or does that insurance cover
The
the storage?
storage insurance can cover it. It does vary by insurance
Yeah, yeah.
company. And the big scheme of things, the bill for the storage seems minimal. It's like $1,000 a year, but but in relation to everything else that you have to go through to like get the eggs retrieved, it's not as significant. But yes, there is a storage fee as well.
Is there an age where you should just not consider? So I'm 42. I
Great
feel old.
question. I actually had a recent patient who was 50 who had a BRCA mutation, and she just had her first child. And she was like, "I want to have more children." And I'm like, "Well, you need to freeze your eggs right now."
Bless her heart.
So yeah, that's very difficult. But nowadays, the reproductive endocrinologists, who are the doctors, they're the OB/GYNs who specialize in like egg retrieval and things like that. They're called reproductive endocrinologists. They have a lot of techniques, and they're actually doing it on patients who are more advanced in age. So like my 50-year-old patient was able to, she had a pregnancy right before she was diagnosed through IVF. So I would say the earlier the better, but it's not impossible even at age 42.
Post-treatment, is that a thing? Is it to do it after you've gone through
We
all of
like
this?
to we like to encourage it before treatment, because as you can imagine, your hormones can fluctuate with that. You're getting medications that can cause significant increases in your estrogen levels. So the medical oncologists typically encourage it before treatment. You can do it after treatment, but you have to talk with them about like a sweet spot as far as timing goes, because patients do get pregnant after treatment. Typically, we want patients to be on their treatment for a year or two before we talk about trying for pregnancy.
Mhm.
I'm told at least 2 years of hormone suppression would be ideal. And those women that I know through the breast cancer community who had hormone receptor positive breast cancers and came off treatment to pursue pregnancies, they generally waited about 2 to 3 years as well. And we've seen some successful pregnancies, but one of the things that my oncologist also shared with me and was like, you understand, was just like the need to warn women about the possibility of infertility after cancer treatments. And 6 years ago, when I was diagnosed, she said it was the number one reason medical oncologists were being sued, or one of the number one reasons was that they were not informing patients of the risk of infertility or giving options. So, I feel like looking back on 6 years ago in her office, like she feels like she did her job. She gave the option like, oh, you should go retrieve some eggs. I'll give you 2 cycles. Oh no, you don't want to do that. You do understand you could be infertile. And I'm telling you this because if I don't, I could be sued. And that was like the extent of the conversation. But again, like we really want to have more detailed discussion and understand the ins and outs way before we ever have to make these decisions. And, you know, even I'm just learning new things, just sitting here talking with you all about it today.
And in addition to, so we have navigators where I work that totally focus on teen and young adult cancers. And so oftentimes the oncologist just totally doesn't have that discussion with these patients. And, or even sometimes when they bring up the subject of fertility, the response from the oncologist is, we need to get you treated right now. And so you don't have time to go through all that, which, you know, for someone who is 18 or 20 years old, and here they are, you know, facing a cancer diagnosis, but then also years later, the possibility of not having children at all. I mean, of course, I mean, that's depressing to them. And they don't know to ask these questions. Their parents don't know, you know, to ask these questions. And so we really have to educate people. Otherwise, they have no clue about, you know, fertility preservation, none of this at all. So these discussions need to be had.
I agree. And I think it's very difficult being like 20 in your 30s, having breast cancer. It's something that no one expects. So it's all a shock whenever we're talking about this in the office. If someone's watching this and they're considering it, I would say to at least speak with a reproductive endocrinologist so that you can gain more information. You don't have to necessarily pay money just to speak with them, maybe a copay for the visit, but at least get more information if you can, so that you can make a more informed decision about whether or not you want to move forward with preserving your fertility.
Well, I have another question here too, because I think it's like I've heard in some scenarios, you know, a doctor creating a treatment plan that sometimes will consider like that wedding that someone has to go to or something like that, or like, you know, having moments where like I'm gonna put off the day that I do chemo because I had this milestone, this family event, this something, you know, or like I really want to save for this birthday. Like how much of these, you know, decisions that, you know, you guys as, you know, many of you here as medical professionals have made, like with consideration of those milestones and those things, you know, because it's like that's why you would think the fertility conversation would come up. You know, you would think it would come up because like you could be making choice about anyone's treatment course in general, about including, you know, the life that they want to live and their quality of life, you know. And so I wonder like how many doctors are making choices based off of that too, you know, not just what the standard of care is, you know.
I'm not medical, but I'll tell you, my doctor did not care about anything I had going on in my. The only thing she was doing was fighting for me. So she kept driving home, Rhonda, this is cancer. And I think that when you are not, I didn't have never been sick a day in my life. I had no exposure to being in no hospital. I didn't know the etiquette. And so she kept driving home. We have to do this. When I was diagnosed officially in November of 22, I was stage 0. By the time I had my double mastectomy in March, and it was a delay because my grandmother died last month, but I had a double mastectomy in March and I was stage 3. You know what I mean? So she was like, we can't play around with you. Whatever you have to do, it has to wait. Your treatment is more important. She was never interested in any of my important dates. I mean, not in a mean way, but definitely patient first. You have to get treated first.
How long of a delay did you say? You said January to March?
November. I was diagnosed November.
March.
And then I had a double mastectomy on March the 9th.
Okay. I have some other thoughts on that, but I don't want to delve into your
I know, is
medical
that a
background
normal amount of time? That
Um,
doesn't seem like a normal amount. It seems like
so I'm actually working on some projects on this, and there are delays within different patient populations, whether it be like how far the patient has to travel to get care. In the Bay Area in California, we have a lot of patients that come from like the Central Valley of California. So that can delay care, especially when you have to like get repeat imaging, or we have to have our pathologists and radiologists verify things. So it can cause delay in care. Yeah,
I'm
yes.
aware of delays. So one of my delays was my MRI. Remember, I was doing all of my testing myself and I was getting great stuff. And then when I went to my doctor
Yeah.
and they said, go to this doctor for this image, and I was like, oh, okay. And I went and they told me that my out of pocket was going to be $1,000. Just getting on their calendar alone took me 30 days. So when I got there and then they're telling me that $1,000 for a copay, I went off on them and my doctor. So then I said, I can go back to the same places I've been going to before. It was nothing wrong with them. They got me in, but by this time we're in January because I had waited to get on their calendar because I thought it was some type of relationship that existed between the doctor and the imaging center. And I found out later that wasn't true. That was delays. Then the other delay was with my insurance type, the specific hospitals that line up, because all the stars have to align for your doctor to work in the hospital, for the insurance to cover both. So that was really what delayed and how we got to the date of March. But I would say it was an imaging issue. So now I tell people you can go anywhere. If it's a place that you're already comfortable with. And I learned, because I thought with the price that my doctor was getting a kickback. So I went to him like, what's wrong with you? I know you're getting paid. And he was like, what are you talking about? He said, Rhonda, we only are referring to know of. It's not because we get anything in return. So that is why it delayed, because I could have gone to my place up the street in December and it didn't work out.
Yes, and you bring up a very important point, Rhonda, and that's what happens frequently with patients who I see as well sometimes. When there is a delay, it's like there's an issue with imaging. We do tend to refer to people we know of. We are not getting kickbacks at all. And for the MRI specifically, I know there are certain places where we will receive an MRI, and I'm not a radiologist, but I look at the imaging, obviously, I have to as a surgeon, and like sometimes the image quality is significantly different and significantly subpar at some of these places. I hate to say it, but it is the case. That can be a delay, especially with insurance companies as well. I have had the same things that you talk about where there are insurance issues as far as like the insurance companies saying that they don't want to pay for certain things that are happening at certain hospitals. And so that is something that is a problem.
Do you find that
But
cancer fast though? I mean, I guess cancer and I know it moves fast, but that was super fast in my opinion, from 0 to 3.
right. So yeah, I was gonna get into that. It depends on the there are different factors that we look at as far as how aggressive the cancer is. So we look at the grade of the cancer, which tells us how rapidly the cells are overturning. Grades go from grade 1, 2, or 3. 1 is low, 2 is intermediate, and 3 is high. So anything that is high grade, sometimes even intermediate, as well as the Ki-67, if that's above 20%, which tells us the percentage of nuclei that have cancer in them, that tells us that it is a more aggressive cancer. And that is when we typically will tell patients we need to get moving on this. There are situations where we feel like we may have a little bit more leniency as far as time goes, and that's when it's a slower, less aggressive cancer. When it's more aggressive cancer, that's when we're trying to sort of move things forward because it can rapidly grow when it's in that situation.
Yeah, I feel like I had like an overlap of all that was explained by Dr. Candace and some of what Rhonda experienced. I just as a physician, understanding Black women, I'm more of breast cancer, and everybody like telling me that, but not necessarily telling me real solutions. I started looking at literature, and I came across all of this literature that the outcomes could very well be different now, 6 years later, but the literature I was reading was saying that if a patient didn't start chemo within 6 weeks of their initial surgery, right? So more to hormone positive as opposed to triple negative patients, that they had more of a chance of having distant recurrences, and they had data. So 6 weeks was the furthest out starting chemo after surgery, and it had the worst prognosis. And then they gave other intervals that were like 31 days plus, and then less than 30 days. So with that data, of course, I was like, let's go, let's go, let's go. And so I was really pushing my oncologist, as well as she was pushing to like hurry up and start chemo. So we agreed that as soon as my chest tubes came out, that was when I would start. And so I started 3 weeks post-op. And it was the day after my last chest tube came out. And I had friends who are breast oncologists, one saying, who's a Black woman breast oncologist, saying, yep, let's go, like, hurry up, let's do this, send me the path, talking about the Ki-67, all of that. And then having a male friend that is a breast oncologist saying, whoa, I give my patients 6 weeks, like, I don't really trust this, you need to go somewhere else. I'm like, dude, I'm trying not to die, like, I got to get this show on the road. But over the course of, I'm going to say, my illness with breast health, even before my breast cancer diagnosis, having had abnormal pathology, switching places where I was getting imaging because of superior but more costly imaging quality at the university hospital, I was having to call and fight with my insurance. And what I said to them is, listen, you can think you want to send me to this place with inferior imaging quality, but I'm here now because not only was the imaging quality less than it was at the hospital center, the radiologist there didn't even read some of the pathology that was found on a previous imaging study. And so I'm not going to the inferior place to get my care. It's going to cost me more and it's going to cost you more. And I've never had to have that argument with them since. And so I know this as a physician and I know this as a patient, just as Valerie did. If you tell the insurance company why it's more expensive for them to not do what your physician is wanting them to do, they will generally budge. But you really have to spell it out and lay it out. And we just have to accept, like, it's not our doctors doing. A lot of it is the insurance, but our doctors are like 1 to thousands, and we are the only person like taking care of us. And so sometimes we have to go to bat for ourselves, and we can do that. And I've encouraged my patients to do that for all sorts of health issues. And sometimes they get the approval before we can get it. So it's just a great conversation to have about self-advocacy, doing the work, like remembering that, like giving your doctors grace and remembering they're humans and they're not just taking care of you, and that you can also help things along. But we just have to be educated and informed in order to be able to show up and advocate for ourselves.
Yeah, we have
Yeah,
our girl boss worksheet is like kind of fun for this, but like it does say, like do your homework, be in the know, because a part of advocating for yourself is like walking into those spaces with the right questions and having the tools that you need to get the answers that are going to answer your questions, like not just beating around the bush. Yeah.
Think so, Haley, the other part of doing your homework is all mammograms aren't equal, and all people reading the mammograms aren't equal. And so oftentimes, we have community places that provide mammograms, but they're not specific to breast cancer. And so we've had patients at, where I work, that they've really had to have someone else to read the mammogram again, and things were missed. And so I think we need to educate the public about where you're getting your mammograms, and who is reading the mammograms. It is specific to breast cancer, and not that they read a lot of other kind of things, well as, as mammograms. So it's an education piece that we just all need to do.
If I could just, conversation makes me so happy, sad, because it's so informative, but it's so scary for all my breast friends who don't have medical knowledge, because your
Hey, Haley, can you me? Oh,
Yeah,
okay.
got you.
you know how to challenge insurance companies, you know what to ask. And I'm sitting here thinking like, man, breast cancer really just happened to us. It just railroaded us right on over because we wouldn't know. I wouldn't know not to just say, because in my financial realm, I own a nonprofit that helps minorities buy houses, and people trust my referrals. So if I say, I want you to work with this realtor and lending team, my client is going to do that. And I'm not thinking that the doctor is making a referral off the cuff. I'm thinking that I have to work with these people going into it to get this information. And the fighting with the insurance company is something I learned when I was trying to get whatever recovery medicine they give you after the Red Devil. I can't think, whatever gets your blood counts right back up. They didn't want to approve that. I ended up having to do self-injections with Zarcio, whatever. And I fought for that, but you don't know. Everything really is hands-on training. You don't know anything.
Yeah. On that note, I think we kind of did talk about Zoladex and maybe why you took it, but what were the good things that came with taking Zoladex? I feel like after the insurance fights and all of the things that came with getting there, what were the good things about having taken it?
Well, I think we're all still cancer-free, so that has to be a test.
Yeah.
Okay.
Zoladex, it reduces your estrogen. I mean, I always felt like I was every woman, but with my estrogen levels, I was every woman. And Zoladex controlled, or it is controlling that. Recently I had to get more breast reconstruction, so they did Zoladex in my back, in my left side, which wasn't as bad. I was just walking around talking to everybody with the ice pack on, but it's not a thing. I can't think of anything with Zoladex specifically where I'm having some type of unbearable side effect. As long as it's doing its part and keeping me cancer free, I'm appreciative.
Know that I had side effects either. I mean, I always attributed them to either the tamoxifen, or I can't think of the medicine. I'm having a brain fog. The other medicine that I took for 10 years, but I didn't even know that you had really bad side effects from taking Zoladex. And I really didn't have hot flashes, but I think that's hereditary because my mom didn't have really bad hot flashes. But the joint things, yeah, just a little bit, but not really enough for me not to stay on the medication. But I think what really surprises me is, the combination of taking the oral medications and the Zoladex, and the numbers of women that aren't compliant, with taking their hormonal therapy, and the recurrence rate. So I'm still not quite sure why that's the case. And I know that they're doing tons of they have in the past, and they are now doing tons of studies on why women decide after a few years not to take their medication. So I took tamoxifen for 5 years. This was after the Zoladex, and then letrozole. That's it. I couldn't remember that, for 5 years. But a lot of people a lot of women do not complete the oral hormonal therapy. And I think it's probably side effect related.
I was gonna say, is it, because again, because you're kind of getting to the point of like why this show is actually kind of interesting to put together, because it was hard to find Black women that had taken Zoladex.
Yeah.
And so I'm wondering, is it because we're like worried about our fertility? Like, what is that? Like was there something there in your compliance moment that you're just talking about? Are there racial components that you see in those trends? Like, I'm just so curious,
I'm trying to take the high road here. I really am, through the lens of a nurse and the lens of a patient. I'm just wondering how many Black patients were offered Zoladex, because even in my support group, there were very few women that were offered Zoladex, and a lot of them were, had cancers that were estrogen receptive, but very few of them were offered that. So I don't know. I mean, it's almost like thinking, why aren't we offered a clinical trial? The same thing.
Yeah. And some of that again is from like a matter of timing, or how often doctors, like, how you guys don't get to spend that much time with your patients in general. You know what I mean? Like, that's just that. And so, and then it's like, is it because like there is some racial bias, right? There's that piece, or is it because they don't want to lose the trust that they've like already created with that patient? You know, there's so many, it can go both ways. I've seen it go so many different ways.
And
Yeah,
see, and this is
Oh,
this
go
is
ahead.
another question I wanted to throw out. So my period came back on. That's why I was, offered Zoladex. But is that always the case? Do they now, are you giving Zoladex even before that happens? So is that part of the regimen? Because 25 years ago, I don't think that was how it was given.
Miss Valerie, I was offered it as a part of my regimen from day one. She gave me the outline of every medicine I would take at each point. So Zoladex was automatically on the list. The only way that anything would come off the list is if I had some type of allergic reaction. But and that's here. And I just want to be, I mean, y'all do this all the time. I'm new. But it's so, to me, it's a demographic. On Tuesdays, I host Tata Tuesdays. I've got breast friends everywhere. And their treatment is so different from city to city, state to state. Can't figure it out.
It is.
Said that you were going to go high. Well, I'm going to go low. And I'm going to tell you why I think some of my breast friends don't keep up with their medicines. Number one, they tired. You know, this is an exhausting commitment to go somewhere to a medical facility. And I think you said you were going for 3 years, or mine for Zoladex is only 2. To keep going back, and my first time back for Zoladex, I couldn't believe they were moving me back into the chemo unit. I was not ready. I thought they were going to give it to me somewhere. So if you're sensitive to that, a trigger for you, like I can't even wear perfumes that I wore during chemo because it's so triggering. They won't go for that. Also, I think with this unique thing that we call social media, everyone is a doctor now. And I know even the reason I created my Breast Friends Network was because I was tired of talking to my friends and them self-diagnosing me or WebMDing me or telling me that different things. I think that those tools have been used the wrong way, and it keeps people from thinking. It gives them a false sense of security. They now have cured themselves. As I tell all of my good girlfriends, we don't do hair. We don't do nails. Why are we doing doctoring? You know what I mean? I mean, if this is what they do, listen to them because they would know best.
Yeah, I agree. And I was going to say the same thing, that, all cancer centers are not created the same. All oncologists are not created the same. And we don't all have access to accredited cancer centers or cancer centers where they're doing clinical trials and cutting edge research. So that the doctor is like on top of things. When I presented at San Antonio Breast Cancer Symposium, my oncologist was sitting there in the audience, and it was a packed room, but not every oncologist in the country was there, right? And so you have people who are committed to being the absolute best. You have centers that are accredited and committing to being and doing the absolute best. And then you have people who are not following guidelines and sort of, getting away with. And then when you look at us as a whole as a community, we're disproportionately impacted by the disease. The disease is more aggressive. You have, doctors who think they're doing the right thing saying, well, I'm treating you just like I would treat my mother. Well, that's very nice, middle-aged white man, but my cancer genetics is not set up the way your white mother's cancer genetics are, or whatever the case may be. And so it's very nice that you think that you're doing something by treating everybody exactly the same, but we're not necessarily getting care that is, patient-centered and focused on us. And then cost is different, access is different. Do you have time? Like, yeah, it's been very easy for me to keep up with my Zoladex. My cancer center is 5 minutes away, and I'm lucky in that there's a new cancer center, so I don't affiliate with my chemo and my PTSD with that building, because Lord knows when I have to go park in the same parking spot I parked in when I was getting chemo at the other building, I want to throw up. I'm raging, but that's not where I go get my Zoladex injection every month. And also, when I miss my shot, they're on the phone. Alexia, did you forget something today? You coming in this afternoon? You coming in tomorrow? 3:20 or 3:40, like pick a time and be here. But I know that everybody is not going somewhere and getting that kind of treatment. And I know that I get that kind of treatment because, oops, sorry.
Uh-oh. She made a really good
Well,
point though.
doctor,
Yeah.
you can go, Rhonda.
How you advocate for yourself. And I remember telling when I went into the cancer treatment center, and 90% of the room was white and 75. I told that lady, listen, you're not gonna treat me like them. You know what I mean? I have a life. I am out here. Like I want whatever you create for me to be for me. I don't want what the book says. I need to know that you're interested in curing Rhonda as an individual. And I made that connection. And Rebel, you're back. She always calls me Rebel, but it's cool.
Sorry about that, y'all.
You're fine, but you were on a roll.
Yeah. What I was saying is, like, over the years of going to the same cancer center, and let me also add in that my cancer center is affiliated with the hospital that my practice is affiliated with, right? So everybody's not going in there with that connection and with relationships and hugging the receptionist and, going there, now at this point, 8 years strong, but 6 years strong as a cancer patient. And so sometimes the way we show up and the way we interact with people makes them remember us, and it makes them not say, woo, I'm glad Alexia didn't show up today because I didn't want to deal with her shit or her attitude, right? It's like, oh, Alexia was on the schedule. We were kind of looking forward to seeing her, and she didn't come for her shot. She's usually here. Let's call her and find out. And we should all get that as people with a deadly or potentially deadly diagnosis. Like, there should be a system in place if someone doesn't show up for their injection or their chemo chair or their doctor's visit. There should be an automatic system in place, but a lot of times there isn't. So what can we do to empower ourselves? I have alarms in my phone. I have alarms in my calendar. I have a 48-hour reminder. I have a 24-hour reminder. I have a 1-hour reminder, and I have a 30 minutes reminder, because the most random thing can take my little chemo brain totally off the fact that I was supposed to run in and get that shot. And you can, if you are so bold, stick that needle in yourself every month. Like, that is an option. And so Rhonda's shaking her head like, no, I'm not doing that. I'm not doing it either, which is why I keep going. But my oncologist was saying, like, you're in your 5th year of Zoladex, and 5 years is the standard of care. But based on your age, your race, your big ass tumor, your 9 of 15 lymph nodes positive, you should really be on this for 10 years. But if your insurance doesn't pay for it, I'm going to try to get compassionate use from the manufacturer. And if they can't, it will cost you this much out of pocket, and you may want to self-inject. Or if you have a friend or a family member that's a nurse, you may want to ask them to inject you. But we're a year out from this conversation, but we're already plotting and planning for it. And sometimes we're waiting till, the 11th hour, and we don't have a plan in place. And, like, I'm somebody who's a big time planner, and for everything in life, whether it's my cancer treatment or who's going to babysit my kid while I go to Vegas for the weekend, I have planned A, B, C, D, E, and F, because I need stuff to work out in my favor. And so we kind of have to learn. We got to learn to get ahead of things. And my mama is relentless. She just gonna keep calling me.
No, but I love the idea I love the way you just phrase, like, we do these things, we plan these things to keep the outcomes in our favor, right? I feel like I think about taking Zoladex or checking your girls every month or all of those things. It's like, you do these things so that you can have the outcomes be in your favor. I think it's a great way to kind of think about that. But yeah, guys, this is a great combo. We are coming to a close. So I wanted to give everyone a chance. I know, right? Say some final last comments, but I think I definitely want to say thank you to our friends at Tercera who sponsored this. Their supporters, their friends, they're great. If you haven't met our friends at Tercera, you can come hang out with them because they're so much fun. But also, like, Zoladex is why some of you guys are here. And so, like, I'm like, that's like a really interesting thing to way to sum it up. You know what I mean? Like, I'm so happy that you guys are here because of this. even if it was one part of that cocktail that Rhonda mentioned, right? It's like it's a part of it, and it's really, really important. But yeah, any other like final thoughts for people to really take away what Zoladex is, how these things, how fertility has been a part of your breast cancer journey, any of those things?
So I think that if you're a survivor and you have people in your community that you find out that they're diagnosed, we should reach out to people, because the fact is most of us, even if you have a medical background, you don't know people that have this information. And so we need to share it with people, because they're totally frightened. And you guys know this, the moment you're diagnosed, you just want to live. So whatever they say, you go for it. But if you know you have time to make the decision, it's a little bit easier. And doctors nor nurses or social workers or navigators ask you, like, what's your learning preference? You know, maybe it's a video, maybe it's conversation. Nobody does that. And so nobody asks you, well, do you have some milestones that you want to get to? That would be lovely. But 9 times out of 10, they don't. And so to have someone to say, listen, ask these questions about your diagnosis, and then say to your team, this is important for me. So what can I do to get to this milestone? Or do I need to do this before I can get to this milestone? And I think that's helpful for people.
Miss Valerie absolutely just touched on why Tata Tuesdays is so important to me, because through our conversations and the stories that we hear from other women, it allows us to know those questions to ask, because we have never done this before. I am overwhelmed by the conversation. I have to go back and talk to my board about how we can show up better, how we can teach our breast friends to show up and make meaningful connections in those rooms, so that when they do miss their appointments, people reach out to them in love. Or the importance of having conversations. I mean, I'm just now being introduced to people my age who tell me I don't take the medicine because I don't want to gain weight. Just those type of things that I was not prepared for when I took on the role of a leader. Thank you so much, Haley. I want to keep the conversation, of course, very relevant all the time, because this is an important conversation to have. Thank you.
Thank you. And I'm going to throw Tata Tuesdays into the blackdoctor.org right now, so people will have access to what you do.
Thank you.
Cool.
Yeah,
Dr. Alexia?
yeah, I think you know, one of the things that sort of keeps me in the game is like knowing exactly how these medications work and why I'm having to take them, right? So Zoladex literally shuts off a signal from your brain to your ovaries to stop you from ovulating and going through the natural hormone cycle that, you know, gives you your natural peaks and flows of estrogen. And then your letrozole or your AIs, they basically stop other cells in your body from making estrogen and feed your cancer. And so just being armed with that information and understanding how things work, and that the two work together, if you're a younger patient or AYA breast cancer patient, or if you got breast cancer before you hit menopause and didn't stay in menopause after chemo, like when you understand why you're doing a thing, you're more likely to do it. Knowing that this enhances disease-free survival, right? That more percentage of women 5 years out and beyond, which is always the goal, and there's still data going, are surviving disease-free with these drugs in combination. For me, like, okay, I'm going out of my way. I'm going to do whatever I have to do to get this drug, and understanding that kind of thing, I think is important to keep people in it. Understanding your doctor gets no kickback from doing this medication is super important. And like, we have to remember that, because we'll come up with all the reasons why we're not doing a thing, right? And we're really essentially cutting off our nose to spite our face, because we're worried about how much money our oncologist is making, instead of worrying about what's the benefit for me, what's in it for me. So I share my story because I didn't have somebody that I could look to and see them walk this walk and live through that and follow in their footsteps. You know, now I do. We've all built this community together over the last several years, and we're all leading by example and just leading by showing up and doing. but yeah, like, why are we doing this? And that is the why.
And I
Thank you.
just want to say something really quickly. I think that Valerie, Rhonda, and Dr. Gaffney all touched on, which is going into these decisions being well informed is extremely important and helpful for your future, especially when we're talking about your fertility. So I strongly encourage you to be a part of Tata Tuesdays or a part of Touch so that you can learn about these things, speaking with your doctor, and asking questions as far as like, what's this medication going to do? Why do I need it? Why is it important? So that you understand the importance of taking it. And that can really help with you moving forward as far as staying on the medication and helping decrease the chance that the cancer does not return.
Yeah, and I think if you're, yeah, like Dr. Candace just said, like we have, even though I might not have the resources because I don't know these things, I can help find these things through Touch. So can Rhonda at Tata Tuesdays. We have access to people who do know these things, the things that we might not know, or the questions to go into these spaces with. And so I think that I want to thank you guys for sharing these resources today. It's been really, really informational. I feel like people that know anyone in this moment in their lives or know any or going through it themselves, I think that we definitely provide some good information today. So thank you guys for sharing your experiences, your knowledge, your expertise in this work. I just put Tata Tuesdays on Black Doctor, Love of My Girls, Touch BBCA, all that we do, because again, we have so many resources. So if you need them, come find us. And thank you for another great pink table talk this month, guys. We will have one at the end of April again, so you're kind of getting a double feature this month. And we will see you guys at the end of the month for another pink table talk.
Thank you.
Thank
Thank
you,
you.
guys.
Bye.
Amazing.